One of my favorite topics to discuss, breast cancer reconstruction. Let's talk about it. So I love meeting breast cancer patients because it really gets to some of the heart of what I do, right? Meeting a person at one of the most trying times in their lives and being able to offer them a solution that helps maintain their sense of self and self-esteem. That's really important to me. So let's talk about and break down what is breast cancer reconstruction and what are kind of the newer developments in breast cancer reconstruction. So generally, cancer patients in terms of surgery are offered one of two surgeries. Either mastectomy, or removing the entire breast, or partial mastectomy or lumpectomy, meaning removing just the tumor, plus radiation. Breast cancer reconstruction can really happen in both settings. It's not exclusive to one or the other. So let's first start with, if you decide to get a lumpectomy and radiation, what can you expect with breast cancer reconstruction? So a partial mastectomy or lumpectomy, again, just means removing the tumor. Removing the tumor can leave a defect in the breast, a hole. And this defect can produce a deformity in the breast, overall breast appearance. When you add a lumpectomy and radiation, the radiation also changes the breast. It typically makes it more fibrotic, meaning harder. It makes the blood vessels fibrotic as well. And so it can drastically change the appearance of the breast. And many patients, if they didn't notice the deformity before radiation, will realize it after radiation. And so the development of oncoplasty, meaning treating the cancer by removing the tumor, while also reconstructing the breast or reshaping the breast in order to maintain an aesthetic appearance, has been really revolutionary. The benefits are numerous, but include the fact that it minimizes the number of surgeries. For many, breast cancer reconstruction happens in stages. And so if you can minimize the number of surgeries, minimize your downtime, that is really important. Additionally, it does not confer increased risk of the cancer coming back or of the patient dying from the cancer that they have currently. And we've looked into whether or not patients are really satisfied with this approach, and have found that by and large, if you're able to keep your breasts, you probably are the most happy with your breast cancer journey and with your body after having gone through that journey. But what about patients who need the entire breast removed? So reconstruction for those patients generally falls into one of two categories. One, implant-based reconstruction, or two, using your own tissue or autologous reconstruction. Again, for much of this discussion, realize that this typically happens in stages. For instance, for implant-based reconstruction, there are typically at least two stages. The first stage involves putting a tissue expander or a flat balloon into the breast pocket that's made after the mastectomy. That balloon is generally filled up over time in clinic, and then after about 3 to 4 months, that tissue expander is then exchanged for a permanent implant. The time variation is determined by really what size you want to be. So the bigger you want to be, the slightly longer time you have to spend expanding the expander to get you to your optimal size. Now, if you use your own tissue, you really do have a lot of options there too. You can use the belly, you can use the back, the medial thigh, the buttock as well, all to basically move tissue from one part of the body to another. When do we choose one over the other? Well, much of this comes down to patient preference. Patients like implant-based reconstruction because it's typically an easier upfront commitment, right? 2 relatively smaller surgeries. Each surgery takes maybe 1 to 2 hours on its own, and then they're done. Autologous reconstruction takes a bigger upfront commitment, meaning you're committing to a 4, 5, 6, 7, 8 hour surgery up front, a few days in the hospital. And because the surgeries are bigger, the risk profile is a little bit higher, at least in that short term upfront. But over time, what we find is that most patients are happier having used their own tissue. They don't have to worry about the long-term complications of having an implant, which can include capsular contracture, meaning that capsule that the body forms around the breast implant can get hard. They also don't have to worry about things like rupture, checking the implant every 2 years, exchanging the implant in 10 to 15 years. You get the point. And so it really is a personal choice. That being said, there are times when we as physicians will recommend one over the other. So if you're having a mastectomy and you are also having radiation, more than likely you'd be better off using your own tissue. Again, the things I said about the skin changes after radiation still hold true. The skin becomes more fibrotic, harder to stretch, and so the complication rate with implants and radiation is higher. You're more likely to have capsular contracture, and you're also more likely to have implant exposure because the skin doesn't really stretch well over the implant. There are ways to mitigate these risks, and by saying that the risk is higher doesn't mean that you absolutely cannot have an implant or radiation, but you do have to be aware that it is a little bit riskier. How about autologous reconstruction and radiation? So again, it is a better match. And then the timing is always a question that you have to figure out with your own surgeon. In my practice, I typically recommend that patients wait until after radiation to have their autologous reconstruction done. And think about it. If radiation makes the tissue harder, then it probably is better to go through radiation, come back, and then put tissue that hasn't been radiated to address that kind of fibrotic nature of the chest wall and of the skin. Now, let's talk about the newer waves in breast reconstruction. So one of these that I have not mentioned at all is fat grafting, meaning harvesting fat only from anywhere you want, really, belly, back, thighs, and putting that fat into the breast. People have successfully reconstructed an entire breast just using harvested fat. And then you can also use it just as an adjunct to other forms of reconstruction. So you can use it with implant-based reconstruction. You can use it with other types of autologous reconstruction. It's not exclusive. And this really is a personal discussion with you and your physician to determine what's the best strategy for you. But fat grafting has really been revolutionary. It does not increase the risk of cancer coming back if you put fat into the breast. Are there risks? Yes. The major risk is that we lose some of the fat that we graft or transplant at any given time. And that loss happens early. The consequence of that is that you may need more than one fat grafting session to achieve your reconstructive goals. If you're building an entire breast, you definitely will need more than one session. And what's been found is that people typically need between 2 and 7 sessions. Now, how invasive is fat grafting? Well, it's probably the least invasive of the ways that we perform breast reconstruction. And so if you do a fat grafting session by itself, it actually is pretty straightforward. It probably only takes 45 minutes to an hour and a half at the most, and you're able to leave the hospital the same day. Now, there's also been a wave of people wanting to keep their own nipples, which typically isn't the case for a standard simple mastectomy. Nipple and skin sparing mastectomy are kind of newer adjuncts to this algorithm. And so historically, nipple and skin sparing mastectomies were really only well advised in patients who had no ptosis, meaning no sagginess of the breasts, and who were pretty small, so A and B cups. When you went higher, what you saw is that you had a higher rate of what's called mastectomy flap necrosis, meaning that the skin and the nipple die after you've had the breast tissue removed for cancer. Well, why is that the case? To understand the answer to that question, you have to understand the anatomy of the breast and what is actually the blood supply to the breast skin and to the nipple. The blood supply to the breast skin and nipple largely come from two arteries that we have within our chest, the internal mammary artery. Now, those two arteries give off branches through the muscle that then goes into the breast tissue itself and then supplies the breast skin. If you remove the breast tissue, you're removing a lot of that blood supply to the skin and to the nipple. And then you're relying on largely, initially at least, blood supply coming from the surrounding chest wall. So the further away those nipples are from the chest wall, the greater the likelihood that that skin, that nipple will die. So how are we able to save nipples if we're doing a mastectomy on larger patients who have bigger than a B cup? So a newer wave has come into play where we're doing a staged mastopexy, meaning a breast lift, or breast reduction before we do the mastectomy. So what that literally does is it moves the nipple up and tightens the skin envelope around the nipple. And in doing so, it does two things. One, it moves the nipple closer to that chest wall, but also because you're making strategic cuts, you're also kind of forcing the body to grow in new blood vessels to kind of supercharge that nipple and that skin, so that when you eventually move the breast skin or remove the breast skin, you have newer blood vessels that are supplying that nipple and skin. So again, it's a staged mastopexy, breast lift, or breast reduction, depending on what size the patient wants to be after all reconstruction is done. The timing of that first stage can happen anywhere from 2 weeks before the mastectomy to a year before the mastectomy. The timing actually, the longer you can wait between the first stage and the mastectomy is probably better, but we can do it even as close as 2 weeks before the mastectomy to optimize the result. And then how about implants? Do we have to do the tissue expander and then implant? No. We can actually do what's called a direct to implant reconstruction, where you're simply, at the time of the mastectomy, putting in an actual implant, and then again, minimizing the number of stages for breast reconstruction. So all in all, we've come a long way and we continue to make progress in this area. What are your thoughts and questions? Leave comments below. As always, love you lots, and bye for now.